Good afternoon, colleagues, and a warm welcome to everyone. Over the past 6 months, we've worked in partnership with colleagues across mental health, adult social care, housing, and general acute hospitals to update the mental health and housing protocol. The purpose of the mental health and housing protocol, something that's been in Surrey since 2016, is to help make the complex mental health and housing pathways clearer and outline how colleagues from different services such as adult social care, housing, hospitals, and community mental health teams can come together to carry out the meaningful work that helps to change residents' lives. So today's webinar will provide a comprehensive overview of what the protocol is and how it can help you in your role. The webinar today is one session among many that we are hosting as we relaunch the protocol across Surrey. Some of the activity that we've led on already includes visiting general acute hospitals, meeting every psychiatry liaison team. Adult social care will have its own specific practice lunch and learn, and working incredibly closely with every housing district and borough. All of this is with the purpose of bringing colleagues together across the Surrey system in mental health and housing. So the session today is an information focused one. So please feel free to enjoy some lunch, grab a hot drink. There will be polls throughout for you to engage in, and you're more than welcome to drop any questions into the chat that we'll be monitoring. And at the end of the session, we'll have some dedicated time to take any questions then from our panel of colleagues from across Surrey and Borders, the general acute hospitals, adult social care and housing. Now, I'm really pleased to introduce my amazing colleagues who are going to be delivering on the content from today's webinar. And I'm going to pass over to each of them to introduce who they are, their role, and what organisation they're from. So, Amy, would you like to start us off?
Yep, thanks, Michael. My name's Amy Morgan. I'm a Senior Commissioning Manager at Surrey County Council, and I've been involved in refreshing the Mental Health and Housing Protocol and working across the Mental Health and Housing Pathways programme of work.
Thanks, Amy. Emma Shirley, I believe you're on the call as well.
Hello, yes, good afternoon, everyone. My name is Emma Shirley. I'm the Team Manager of the Mental Health Hospital Discharge Team with Surrey County Council, and I've been involved in this project as well.
Thanks, Emma. Joe?
Afternoon, everyone. Really nice to see everyone. I'm Joe Bell. I'm a Programme Manager of SABP. I've been working on this with everybody on the call, so love to see everyone.
Thanks, Joe. Knowledge?
Afternoon, everyone. I'm Knowledge. I'm the mental health lead for Friendly Health.
Thanks, Knowledge. And last but not least, Ikvinder?
Afternoon all, nice to meet you all. Ikvinder Sokol, Head of Housing Solutions at Runnymede Borough Council. Been working alongside Michael, Amy and other colleagues on refreshing the mental health and housing protocol.
Thanks everyone. So you can see we have our all-star lineup to present all the content today. So I'm going to hand over to Amy first, who's going to be introducing what the protocol is and just some key components of it. So thanks, Amy.
Lovely, thanks, Michael. So we've already talked a little bit about what this session's going to cover. Obviously, the purpose is making sure everyone's aware of the protocol and just bringing everyone together so that we can improve collaborative working across mental health and housing. So we're going to talk about how it relates to your role. Talk about how it relates to your role and how to build awareness of how your role contributes to the overall solutions. Look at some operational scenarios linked to various sections of the protocol, and then identify any further knowledge gaps that might be needing to be picked up and addressed moving forward. Here is a list of the contents of today's session, so you can see it's fairly comprehensive, talking about what the protocol is, the legal framework, defining the lead professional role, and then going through identifying housing need and what to do when there is a lack of identified accommodation, as well as how to support people who are in mental health crisis. So firstly, what is the Mental Health and Housing Protocol? We're going to look at the purpose of the protocol, the principles that guide its implementation, and some key messages to support its implementation as well. The Mental Health and Housing Protocol offers a structured step-by-step approach to identifying and addressing housing challenges for individuals with mental health needs, ensuring a coordinated support approach across services. It was actually established in Surrey in 2016, and we've refreshed it to ensure that it promotes a proactive multi-agency approach to supporting residents with mental health and housing needs. It really aims to bring together various different services and ultimately aims to help individuals secure or maintain stable housing and prevent homelessness and promote long-term well-being. Early intervention is crucial. You'll hear us talking about this all the way through the presentation, but ultimately identifying and addressing housing needs promptly can prevent crises occurring, can reduce emergency department visits and avoid hospital admissions or delays in discharge. And the protocol really does aim to prioritise or to prioritise individual rights, safety and well-being, and ensure that all decisions are person-centred, legally compliant, and aligned with best practices. So just going to very briefly touch on homelessness and housing instability, because Ickvinder is going to talk more about this later on. But according to the Homelessness Reduction Act 2017, a person is homeless if they have no accommodation in the UK or elsewhere which is available for their occupation and which that person has a legal right to occupy. A person who has accommodation is to be treated as homeless where it would not be reasonable for them to continue to occupy that accommodation. And they are threatened with homelessness if they're likely to become homeless within 56 days. So there are lots of different types of homelessness. It could be that people are living on the streets or sofa surfing. They might be threatened with homelessness if they're facing eviction. They might be living in unsuitable accommodations. That could be accommodation that's overcrowded, unsafe, or poorly maintained. They may have difficulties with neighbours or experiencing antisocial behaviour, or they may be a victim of cuckooing, which is where perpetrators might take control of somebody's home for criminal activity, leaving that individual very vulnerable and unsafe. So just to briefly run through the general principles in the protocol, it is a person-centred approach. Everything we do needs to focus on the individual's rights and preferences. As I said earlier, early intervention is absolutely key. We also want to prevent escalation, so we need to be very proactive in recognising early warning signs and taking action before issues grow into full-blown crises. Collaboration and respect. Obviously the protocol is encouraging us to work very closely with our partners across many different services, and that collaboration does rely on mutual respect for each other's expertise and knowledge. Safety and well-being, obviously we're trying to prioritise the security and stability of individuals at risk of homelessness. We're looking to continually improve on the status quo, hence the fact that we've just refreshed this again. And another guiding principle is to promote well-being and support that long-term stability in the community. And finally, all actions must align with statutory laws, fairness and individual rights. The legal framework that we're working within, I'm going to give a quick overview of relevant legislation and some key principles on sharing information. I'm sure many people will be aware of this on the course. I'm not going to dwell on it, but the protocol is operating within a legal framework, and the key elements of the framework include the CARE Act, the Mental Health Act, so that's governing detention, treatment and discharge, with a focus also on section 117 aftercare, the Housing Act, which establishes the legal framework for preventing homelessness and offering support to individuals who are threatened with homelessness, and statutory guidance on adult safeguarding and homelessness, which mandates multi-agency collaboration to address those safeguarding risks, and of course the Mental Capacity Act, which provides a framework to empower and protect individuals who may lack the capacity to make decisions for themselves. And when it comes to information sharing and safeguarding, do we need to share information with each other? I'm hoping that the answer to that question is quite obvious. Yes, we absolutely do, if it safeguards or prevents delays. And under the Care Act, agencies are supposed to share information to promote wellbeing, prevent delays. Consent is always sought where possible, but it's not always required if there are safeguarding issues or it prevents delays. Information does need to be proportionate, relevant, and shared responsibly within statutory timescales. And obviously, if there are safeguarding concerns, I've put the number up there for Surrey County Council safeguarding issues. Moving on to define the lead professional roles. So who is helping and when? The protocol helps to clarify roles. Essentially, the lead professional is responsible for coordinating support for individuals with both mental health and housing needs. And while they may not be directly providing every bit of that support, their role is very crucial because they are ensuring that that individual receives the right services at the right time. So essentially, they are acting as a navigator for the individual. They're making sure that the right agencies are involved and working together. So they have a really key role. And I think it's important to note that the lead professional's role may change depending on the individual's circumstances and their stage of care. But it's that flexibility that's really important, just to make sure that their needs are being met by the appropriate professionals. So any of these individuals could be the lead professional, so clinical staff and ward staff, housing staff, the discharge coordinator. That role can be undertaken by different people in different acute trusts, not always called a discharge coordinator. Mental health social worker, that's particularly where the individual has broader adult social care needs, and anyone working in community mental health provision as well. So a community mental health nurse or a practitioner, could act as the lead professional depending on the circumstances of the case. So just for a quick kind of case study discussion, we're going to put a poll up shortly to see who you think would act as the lead professional in these scenarios. So the first one is where an individual has been admitted to a hospital ward. After completing an initial assessment, that individual is found to be homeless. So who do you think the lead professional should be in that scenario? The second one is where, during a home visit, a social worker can see that the property that someone's living in is not fit for habitation, might require an inspection by the local environmental health team. Who should take the lead in coordinating that support? Scenario 3 is where a community mental health practitioner has visited a client who's been staying at a friend's house, but is now being asked to leave within the coming weeks. Who's going to take the lead in coordinating support? And finally, an individual who is rough sleeping attends the emergency department due to a mental health crisis. They're not currently engaged with mental health or housing services. So who would take the lead in coordinating support in that situation? So Michael, I think you're going to put the poll questions up on the screen.
I am indeed, thank you. So through the magic of Teams, they should be on your screens now. So please do take a moment to read through those again if you need to. And like Amy mentioned, it's about identifying who that lead professional will be based upon the scenario and circumstances that that individual would be supported in. And there's those 5 answers that you could choose from. So whether it's a clinical staff or ward staff, housing staff, a discharge coordinator, which can change upon general acute hospitals, mental health social worker, or community mental health practitioner. And you'll be revealed with the answers at the end.
Okay, thanks, Michael. So hopefully you're seeing what the answers are, but essentially it's kind of a trick question because it's whoever's most involved at that time. So for scenario 1, that would be the discharge coordinator. For scenario 2, it would be the social worker. For scenario 3, it would be the community mental health practitioner. And for the final one, it would be the lead clinician in the emergency department. So I'm going to move on now and hand over to my colleague Ikvinder, who's going to talk a little bit through identifying housing need.
Thank you, Amy. So to to kick things off, we're just going to be looking at, as you'll see out there, kind of identifying homelessness risks in hospital and in the community. We'll be looking at how we address unmet adult social care needs and the topic of lacking capacity in the Mental Capacity Act. So moving swiftly in. Next slide, please. Just regarding identifying homelessness risk factors and causes in mental health cases. So early identification of these factors we feel is crucial for preventing crises, reducing delays, and ensuring the individual gets the right support at the right time. And by really recognising the key indicators, we can proactively address housing issues before they escalate. So first thing about homelessness status. So we need to identify the individual's homelessness status. That'll be, are they currently homeless? Are they at risk of becoming homeless within the next 56 days? Getting an understanding of their immediate housing situation, which will help gauge urgency of intervention and crucially sort of crack on with steps for support. We also have accommodation details. This includes looking at the type of housing the person is living in, their address history, how long they've lived in the current accommodation, and what that information provides is insight into whether the individual is in temporary or unstable housing, which might in fact increase the risk of homelessness. Next, we'd also look at local connection there. Which local authority do they have ties to? So it's important for understanding where the person may be eligible for housing support, as certain housing services may only apply to those where a local connection to that authority exists. One of the most critical factors to assess is whether there are threats to accommodation. So has the individual received a notice, and what is the reason behind their risk? And again, that early intervention will help prevent eviction or further destabilisation, ensuring we get the appropriate actions before a crisis really occurs. A couple of other factors, so safety and habitability of the accommodation. So is it safe? Is it habitable? Is it basic utilities? As we all well know, unsafe and uninhabitable living conditions can seriously impact upon the individual's mental health and their ability to maintain housing. There could also be legal barriers. Are there restrictions preventing the individual from returning to their accommodation? So this could include legal issues like bail conditions, injunctions, court orders, and they can complicate access to housing, so must be addressed in the support plan. Another important area is housing authority engagement. So has the individual already been referred to a relevant local housing authority? And connecting that with that housing authority early and as quickly as possible ensures that the support is actively being pursued and the individual's housing needs are kind of formally recognised. Access issues is another factor that must be considered. Does the individual actually have keys to the accommodation and the ability to return home? If that is an issue, it could indicate further housing instability or difficulty maintaining their situation. And again, it needs to be addressed to prevent homelessness. So I think overall what we take from this is early intervention is key. And I don't apologise, I'll be repeating that point again and again. Really, couldn't stress it enough. By recognising and addressing those homeless risks, we can really prevent crisis situations, reduce delays, and more importantly, ensure that the individual receives the appropriate support before they lose their home. The quicker we intervene, the more effective and the higher chance that we provide long-term support and stability for that individual. So moving on, we're just going to look at the key steps following admission. So up on the screen there will be the various steps. I'm going to take you through step by step. So step one, upon admission, the clinical staff on duty will complete an initial assessment form and to identify the needs, and that should happen within 72 hours. If it's for mental health inpatient units, this will be done by a discharge coordinator. And it'll be looking at things like ascertaining the individual's discharge destination upon admission. Have questions regarding discharge accommodation availability and suitability, and also identifying if the individual's not registered with the GP. Then ward staff should be doing that things to support them to get them to do that. And as we know, so no fixed address or immigration is required for this. So that should happen at the early stage. Step two, if that person is admitted to a ward, the discharge coordinator should be informed of any potential barrier to discharge during the next MDT, also known as the multidisciplinary team review, within 1 working day. So within 72 hours of that, the MDT reviews care plans, identifies discharge barriers and assigns actions to resolve issues. So any external referrals can be discussed with the discharge coordinators, social workers or MDT, or any other external agency needed to support with kind of pre-planning discharge. Other steps within that, for the mental health inpatient unit setting, the discharge coordinator will contact CMHRS rapid response worker to again coordinate an action plan at the earliest stage possible. And the discharge coordinator would then inform the ward of any accommodation concerns and facilitate collaboration between the individual and the community teams for joint plan for discharge. Step 3. If the person is on benefits, has capacity and consents to sharing information, then clinical staff on duty should notify an agreed contact of the DWP of the expected duration of the stay. And obviously that could be approximate, very difficult to tell at times, and any changes to the person's income or family situation, or assist the individual in updating their UC, Universal Credit Journal. Step 4. If the person is already in accommodation, then clinical staff on duty should take the following actions. So for social housing tenants, you'd inform the landlord with the tenant's permission. If they're in private housing settings, you'd notify the local housing options team with the tenant's permission if the admission might negatively impact their housing, where there's a risk that they could lose that tenancy or that the home may no longer be suitable for their needs. Or if the individual is part of the council's rent deposit scheme, and my housing colleagues on this call, a lot of them will be participating in a rent deposit scheme. People paying their own mortgage, you'd be sort of ensuring that the person claims whatever benefits they're entitled to. Those with supported living tenants, with the consent, obviously inform the provider, and same with residential nursing placements. So I'm going to ask my colleague at Adult Social Care for the next slide, please.
Thanks, Ickvinder. So this is about addressing unmet adult social care needs. So if we identify that somebody might have an appearance of care and support needs, then the discharge coordinator or that lead professional should refer them to adult social care for an assessment of their needs, with their consent to do that whilst they're still on the ward. If the individual refuses, the clinician can still refer them under Section 11 of the Care Act if they believe that the person lacks the mental capacity to provide that consent and there is that appearance of care and support needs, or if you believe or there's evidence to show that that person's at risk or experiencing abuse or neglect. So adult social care will aim to triage the referral within 72 hours. If the referral is accepted, if there's sufficient appearance of need and we have that consent or evidence around the capacity or the risk, then we'll allocate a key worker to begin the assessment and discharge planning alongside the professionals that we've already been discussing today. So eligibility for adult social care services is based on the national criteria which is outlined in the Care Act, so it doesn't necessarily equate to accommodation. And as the estimated discharge date approaches, then the discharge plan will be finalised. So ensuring if that person does have unmet eligible social care needs, then services or signposting is in place for those areas. Pass them back to you, please.
Yes, thank you. Back to me. So again, we're going to look at now addressing some of the lack of identified accommodation. So as you'll see, there's bullet points of what we'll be covering. So if we move on to look into each of them in depth. So there's various situations where individuals may not only already be homeless, but could be at risk of homelessness within 56 days of arriving in hospital or in the community. So one of the first risks we need to consider is eviction and homelessness prevention. So if they are facing eviction from private landlords, social housing, family or friends, then the lead professional needs to submit a duty to refer, so also known, people refer to as a DTR, to the local housing authority, and that is a key step in ensuring that individuals are referred to the appropriate housing services that can assess eligibility and provide necessary support to prevent homelessness. You'd also be looking at environmental health risks, unsafe, deteriorating living conditions. We would have all come across cases where there's hoarding, damp, infestations, and that kind of serious housing instability that can lead and potentially even to eviction. And in these cases, the environmental health team and the adult social care can step in to address the situation and intervene when necessary to make sure that the living environment is safe and habitable. Also, maybe experiencing difficulties with neighbours, and that could lead to housing issues, so disputes, antisocial behaviour, or even indeed legal challenges. And in these situations, housing officers or tenancy management teams are the key professionals to assist to kind of mediate disputes, address that ASB, and potentially manage any legal interventions that may be needed so that we can preserve that individual's housing situation. Lastly, again, sadly, we might have been aware of cases regarding cuckooing and exploitation. So when an individual's home is being taken over or exploited by others in a harmful way, it is essential to refer the individual to the community harm and risk management meeting. So might have seen them referred to as CHARMS, where a multi-agents team can provide that coordinated support. And if necessary, obviously safeguarding referrals should be made to ensure that the individual is protected from exploitation and harm. So we're just going to delve into the duty to refer a little further. And what that does is requires healthcare professionals to refer individuals who are homeless or at risk of homelessness to local housing authorities. And it applies to individuals who are homeless or at risk of that within 56 days. Referrals should be made with the individual's consent where possible. And it's really crucial that we get the sort of timely access to housing resources to prevent any prolonged homelessness. And the lead professional is responsible for completing that duty to referral, which would typically be a healthcare professional, for example, a clinician, discharge coordinator, amongst other colleagues who coordinate the care and support of the individual. So just going further a bit into that, it's really crucial that we gather all relevant data before completing the duty to refer form, as outlined in the identifying needs section. The lead professional is responsible for submitting the referral. While the form's consent is nationally standardised, what you'll find is that each district and borough has its own online version that must be completed. So what happens next? Once the referral is made to the housing authority, the housing options officer will start their investigation. They'll engage with professionals to potentially take a multi-agency approach in order to prevent or relieve homelessness. They'll be looking at things like eligibility. Are they eligible for assistance? And if no, a statutory decision will be issued. And if yes, then a housing assessment would be conducted. Do they have local connection? So the authority determines if the person has a local connection or affecting access to housing. Do they have priority need? So that could be a variety of issues, covering some of them. So do they have children, mental health issues, vulnerability? That would give them priority need for purposes of further assistance. Or are they intentionally homeless? And that's where applicants who are eligible and homeless or threatened with homelessness, would have an assessment. And to determine intentionality, you'd be looking at the circumstances that have caused them to be homeless, their housing needs, what accommodation would be suitable for them and their household, as well as kind of the support that would be necessary for them to sustain accommodation. Usually then a personalised housing plan is written up, which will detail how the local authority and the applicant will work together to prevent or relieve homelessness. And the aim being is to make sure that, where they have somewhere suitable to live for at least next 6 months, and take reasonable steps towards that. It does not mean that the local authority must provide kind of housing. So next slide. When it comes to emergency accommodation, bed and breakfast should always be considered as a last resort. We all know the acute pressures around housing and temporary accommodation, but we do stress that bed and breakfast placements ideally be last resort. And it's a collaborative effort in health professionals and adult social care teams, ensuring that the individuals are appropriately supported, and we can follow clear guidelines when considering these types of placements. So eligibility for bed and breakfast should only be arranged under certain conditions where there's no recourse to public funds. They may not be eligible for any other forms of housing assistance, and a bed and breakfast placement could be considered. It could be a local housing authority assessment if the individual is eligible, but assess them and determine there's no duty to provide emergency accommodation, then a bed and breakfast may be used as a temporary solution, or a last resort if the local housing authority has exhausted all other accommodation options, then such a placement should only be used as a final resort to ensure the individual is not left without shelter. Where possible, these placements should be within Surrey, and again, the pressures around that and securing sort of temporary accommodation within boroughs. But that, really that needs to be the aim, to ensure that individuals have access to essential support services, including home treatment teams, CMHRS, community mental health recovery services, and it helps to keep that continuity of support and reduce the risk of isolation or, crucially, disruption in treatment. So we're going to look at some of that in more detail. So local connection. A local connection is where is with a local housing authority, and they'll play a key role in determining whether they can access support and services. So we're going to look at the definition of that, and it's where a local connection is where an individual has it with a housing authority if they meet one of the following criteria. So it'd be residence, you'll see there, at least 6 months in the last 12 or 3 in the last 5 years. It could be through employment, if the person works in that district or borough, or family associations where they've lived for the last 5 years, or other special circumstances which would become apparent in any housing assessment. So whilst people facing homelessness can approach any local authority for support, typically referrals are made to the housing authority even where they have a local connection. However, housing authorities are still required to assess an individual's needs and provide emergency support even where no formal local connection exists. And it's crucial to remember there's some exceptions as well where no local connection is required, or people under, for example, domestic abuse survivors, care experience, young people and refugees who may not be able to access support, who can access support in any area regardless of that local connection. Just at the bottom there, we've got there a key common misconception. So a hospital stay or a supported living placement does not automatically create a local connection. So just something to bear in mind. And the next slide, we're passing to Joe, I believe, initially.
Yes. Thank you very much. So, key points on this slide. When someone is admitted to hospital or mental health inpatient unit, it is critical to assess their housing situation early on in the process and ensure it leads to a safe and timely discharge. If the person lacks accommodation or will be made homeless within 56 days, a duty to refer must be completed, and we've covered off what that is. The lead professional meets with the individual within 48 hours to discuss the referral, and a duty to refer is submitted within 24 hours, including key details such as the personal information, immigration status and previous address. The protocol has a really good full list of the situations and the bits of information you might want to include, so go to that for further guidance.
Okay, back to me for a few more of those points. So step 3, what we've got here, the next option is housing options officers from local authorities will respond within 2 working days to confirm receipt and potentially request further information. The officer will also conduct a housing assessment, and that should be within maximum 7 days of receiving that duty to refer. There'll be a housing assessment meeting. We'll assess whether local housing authority has a duty to provide accommodation and explore other options, and feedback should be given to that referrer within 1 working day. It is really important that we include that housing officer in discharge planning meetings to ensure that there's a coordinated approach. So if the person is medically fit for discharge and a homeless duty is triggered, then housing services will identify a suitable address for discharge. So again, ward staff or psychiatric liaison services in acute general hospitals must ensure that a home treatment or mental health clinician conducts a visit within 72 hours of discharge. And ideally that happens really within 24 hours. And then ongoing visits should then be set out for sort of 7 to 21 days thereafter. They should also notify housing benefit or the DWP if the person receives benefits and invite relevant parties, for example, iAccess or probation, to discharge meetings. And for any Section 3 detentions, a Section 117 meeting must be arranged with adult social care to coordinate a discharge plan. If the person is actually homeless, and may have priority need, the local housing authority provide them with interim accommodation pending inquiries into their homeless application. And if there are no available interim accommodation options, as we've touched on, emergency bed and breakfast accommodation may be required, and ideally placed within Surrey, as we've just discussed. If the person's not eligible for assistance under the Homelessness Reduction Act, the local authority must provide information and advice to help the person prevent or resolve their homelessness. So it could be exploring alternative options such as night shelters or emergency housing. But if the individual has care or support needs, the local authority may need to consider additional support options, potentially under the Care Act or under the Mental Health Act, to ensure that the individual is not left without essential care or housing. And in cases where the local authority themselves can't provide immediate accommodation, then the hospital or mental health services may need to arrange temporary accommodation, and that could be bed and breakfast as part of discharge planning. So over to Joe again, I believe.
Thank you. So ward rounds provide a really, really good opportunity to work collaboratively and put into place a lot of the content that we've just gone through. So the key important points from this slide for me are important to collaborate, particularly when working with housing colleagues and adult social care. Get them involved in the ward rounds. There's absolutely no reason why they can't be. It's not a formal assessment under the housing under the Homelessness Regulation Act, Homelessness Reduction Act rather, but offers a valuable opportunity to assess the needs, explore the options, and share the critical information and put the patient at the centre of the discussion. Opportunity for housing and adult social care professionals to understand the full scope of the individual situation and the risks, not just about the ways that they may already be aware of, but also about the wider ones. And also about assessing the needs, exploring options, and sharing further information. It is important that we understand the individual's preferences, so their values, their goals when it comes to housing, and their expectations. Opportunities to identify the necessary support to ensure that the individual can maintain a stable accommodation. And again, I think it's that maintain stable accommodation is the key bit there. And opportunities to address wider needs. So again, ensuring that from a mental health perspective, that we're looking at the sort of substance use issues or any sort of financial support, etc., and social connections, and making sure that all that wider wraparound support can also be put in place when we're planning for discharges.
Thanks, Joe. So, Knowledge, I'm going to hand over to yourself to run through the process of identifying accommodation in an emergency department.
Michael. Yeah, so patients who present to ED, either they are brought by ambulance or they came in by themselves. Within ED, we've got a triage tool there, which looks at social circumstances. So through those questions, an individual might mention then that they are homeless. We've got a section which looks at safeguarding. Are they a vulnerable individual? Are they at risk of exploitation? Is there domestic violence? We look at all those things. So if they are a yes on those things, obviously we raise a safeguarding concern and share with colleagues in the local authorities. We might also ask if they say they are homeless, we want to know why they are homeless. Where was the last place that they were living? So we've got discharge coordinators who will be in ED once someone has been identified that they need accommodation. I mean, this information I spoke with our discharge team because they are the experts in that. So if an individual presents to ED, maybe they have chest pains, they've been checked out, they've been medically cleared, they are independent, they've got capacity, then obviously we still have a duty to refer. So we will do that. I'm told in some cases, then the individual will be given the reference number for that referral, the discharge summary, then they might present themselves to the local authority. In some cases where they still have to stay with us because they need treatment and all that, then they will be admitted to the wards. I've been told sometimes the discharge coordinators will have discussions with the housing officers. In some cases, they might visit that individual in hospital and have further discussions. There it depends then, because if it's someone with mental illness, they came through ED, maybe they end up being detained. They went onto a ward, maybe they had medical needs, or they're just waiting because a bed could not be found. So from us, if they've been detained, then if it's SABP, they'll go to SABP. But those discussions, trying to identify whether they are homeless or not, that starts in ED. I've been told for those who might not have a recourse to housing needs, there's a homeless pack that individual will be given as well, so that they might try to find support there. I've been told the social care teams who are based in the hospital, they don't deal with the accommodation in hospital, although they still get those referrals from the wards. So there are different issues in terms of what happens. But I've been told if a person has got capacity, mobile, there are no other concerns that have been raised, then they will be given that reference and they will go. But in case of where, of course, there have been things that have been highlighted, then we are not just going to discharge someone, even if they've got no housing needs. We'll admit them, and then those discussions will continue until maybe there's a solution to support that individual.
Thanks, Knowledge. Really appreciate it. And Emma, back over to yourself from Adult Social Care.
Thank you. So the Mental Capacity Act is a key piece of legislation that guides how we support individuals who might not have the capacity to make certain decisions for themselves, whether it's about their housing, their care, or their treatment. So understanding the Act is crucial for ensuring that we're respecting people's rights, providing appropriate support and making decisions in their best interest where they lack capacity. So we have a spotlight within the protocol around the Capacity Act. And I would just caveat, I guess, we have a slide within this webinar, but this is obviously can be a very complex piece of legislation to use and apply. So we've just pulled out sort of key highlighted points, to be honest, but this is much more complex than one slide. So firstly, around assumption of capacity. So a person is always presumed to have capacity unless there's reason to doubt it and their thorough assessment has indicated otherwise. So just as part of that, it's important to consider about who's best placed to carry out that assessment. So generally that is about what the decision is to be made, who's the most appropriate professional to complete that assessment. And just to bear in mind that people's capacity can fluctuate, particularly when we're talking about hospital admissions. It may be that impairment to their brain is temporary and we could wait for that to have the required treatment to then consider their capacity. Best interest meeting. So if a person has been found to lack the capacity to make a specific decision, then a best interest meeting should be held with all relevant healthcare professionals, families, carers or legal representatives to discuss those discharge options or housing decisions that need to be made. An application for homelessness assistance cannot be accepted by a local authority from a person who lacks the mental capacity to make it. So it's the responsibility of the local authority to decide whether the applicant has the capacity to make the homeless application or not. A professional medical opinion could be sought, but cannot replace the decision of the local authority. And if necessary, the Court of Protection can appoint deputies to make decisions, which includes making homelessness applications for those who've been found to lack the mental capacity to do that. Independent mental capacity advocates. So if there is no suitable representative, so an appropriate, say, family member or friend, then an independent advocate must be involved as part of that capacity assessment and that best interest decision making process to make sure that their wishes, that their rights are being promoted throughout. And lastly, just touching upon safeguarding. So it's something that local authorities must be considering in terms of housing and how support needs are met, and bearing in mind if there are any concerns around safeguarding, so that risk or experiencing of abuse or neglect, which is considered under the Care Act legislation. Whistle stop tour.
Okay, thank you very much. So this is now about John. I'll give you a couple of moments to read it, but essentially John is at risk of homelessness and his mental health, and he has mental health concerns, and they still pose a significant risk to his health and well-being, and could lead to further deterioration if he does not receive appropriate support.
Thanks, Joe. So essentially we're looking here at kind of who's the lead professional, what steps should have been taken or have been taken, and who should be involved. So have a little minute to think. But essentially, kind of an SABP discharge coordinator is the lead professional, and they coordinate referrals and external agencies and external stakeholders. So in relation to John, his housing needs should have been captured at the point of admission. So this will now lead to delays in terms of what steps that need to be done. A duty to refer needs to be completed, and it's critical that the housing officer is invited to ward rounds and understands fully how John's needs present and how they'll be supported by community teams after discharge. But one more case study, I'll pass over to Joe to explain.
Yeah, so thank you very much. So this scenario is about Sarah. So Sarah has been served with an eviction notice and is struggling with her mental health, and obviously is at risk of being homeless. I'll give you comments to read it in detail, and then obviously Ivinda will help us answer the questions.
Yeah, so you'll see the questions there, same format as what we just looked at in the previous slide. But again, community mental health practitioner is the lead professional, and they should contact the local housing authority to through a duty to refer form with a copy of the eviction notice attached. And then the housing service will make relevant inquiries into the cause of their homelessness. And if they are satisfied that the individual is eligible and homeless, then they will arrange a housing assessment. If the individual approaches the housing team directly, then housing will liaise with the lead professional who's supporting the individual to ensure mental health support is provided. And if the individual is in the community and then there is not a lead professional supporting the individual, then housing will need to provide a referral to community mental health services. Where appropriate and proportionate, that lead professional must share an updated care plan, risk assessment, and preferably a crisis and contingency plan detailing support during a crisis. The next slide, I'm going to ask Emma to come in.
So another spotlight that we've included within the protocol is around no recourse to public funds, which is often abbreviated to NRPF. So it can be a crucial issue that impacts both mental health and housing. So this we're talking about here that individuals who have an immigration status which restricts them prevents them from accessing certain public funds. So that can include local authority homeless support. So while they can face significant barriers, there are steps that we can take to make sure that they've received the appropriate support or onward advice and signposting. So it's important to highlight that individuals who are no recourse to public funds are still entitled to have a Care Act assessment. So the actual assessment can take place. How those needs are evaluated and how they are met, if they have unmet needs, is the part which is looked at more closely if they don't have access to public funds. But it still ensures as a local authority that we have looked at providing information and advice on how those needs can be met. So alternative housing options can be available, though they can be limited. So it is things that I'm sure that lots of people on this call, we have come across it, where we should be going or where we should be signposting. So there can be night shelters that can offer temporary accommodation. There are also specific no recourse to public funds accommodation options, which are organised through third party or voluntary organisations such as NACCOM. And it might be that they are able to access some support, asylum support, through agencies such as Migrant Help. So it's important as professionals that we remain aware of what organisations there are in our local communities that we should be linking in with and signposting the people we're working with too. So from a mental health perspective, mental health services generally do not fund housing unless the accommodation is integral to their treatment or recovery plan. For example, that could be when an individual's entitled to Section 117 aftercare as part of the Mental Health Act. It could be that accommodation is included as part of that entitlement. However, beyond those cases, mental health services generally not responsible for providing houses. So we need to think about when we're working with people with no recourse to public funds that we're signposting them to gain appropriate legal advice. It's clearly can be quite a complex issue, so encouraging those individuals to get legal guidance, help them to clarify their entitlement and their rights, to make sure they're getting the right support. So it could be referring them on, signposting them to immigration solicitors or support services. That could include signposting them to Citizens Advice locally. So I guess just in terms of our responsibilities as professionals, making sure that we're referring them on, signposting them, for example, to Migrant Help, exploring with them whether they have support from family and friends, thinking about their employment so they can become more self-sufficient, or discussing voluntary options. And we've included there on the slides and also within the protocol the contact details for Migrant Help. So although it's important to say we can't give legal advice as a local authority, we can refer and signpost them on to those advisors. So it continues to be a challenging area for some. It's important just to remember that you can refer them on for that care assessment if there is that appearance of care and support needs and they do consent to it. And onward referrals can still be made for advice and signposting.
Okay, so I think we can all agree throughout the whole session today, collaborative working has been a real key feature and it is so integral to this. We cannot do this in isolation, and I hope that message is coming through loud and clear to everyone that this is a real team effort. So the next section looks at how we will work as an MDT, multidisciplinary team, and the escalation routes to resolve housing issues. So the key points for me are risk is shared responsibility. So again, as we articulated throughout some of the previous slides, what the risks may be, and again, they should be identified early on in the processes to allow plenty of time to mitigate them and put appropriate support in place. Involve partners in key meetings. So again, we've talked about the ward rounds. This may be that we invite housing colleagues to join discharge planning meetings, the MAID meetings, and again, make sure that we're closing that gap around the support and working together collectively and collaboratively. Housing providers are not expected to manage ongoing mental health risks, so those risks will be owned and managed predominantly by the Mental Health Trust. Individuals who have the discharge, who have been discharged from mental health inpatient services are discharged back into the community mental health setting with the community teams there to support them. And again, those wider healthcare needs being supported by various healthcare professionals and support from the community mental health teams and adult social care where appropriate. Support and community resources ensure that the right support is in place, including mental health services and community networks, etc. Really making sure that we're meeting their holistic needs of the patient. Discharges should be made using a structured multidisciplinary team approach. So again, getting the right people in the right room at the right time, ensuring that all voices are heard and risks are managed collaboratively. And again, maybe that someone owns the risk, but other people may contribute towards some of the mitigations. And housing teams do not have the clinical expertise to assess those risks, but are a key part of the multidisciplinary teams and should be informed and engaged within the discussions, and so that they've got that awareness and can feed in any additional information they may have on the topic.
Thanks, Joe. Oh, sorry, I forgot my camera was off. So I think that leads nicely into kind of the first level of escalation. So in the protocol, it sets out 3 escalation levels, but initially that's just about having a multidisciplinary team meeting to tackle any kind of discharge related issues, but also any broader systemic challenges. And this process is really about identifying problems early, addressing the root causes and finding solutions that benefit both the individual and the system as a whole. When a case is escalated, we absolutely need to ensure that everyone involved is really clear on their roles, their responsibilities, and the actions needed to move things forward. So there's some key representatives listed there, depending on the nature of the case. But one person needs to kind of coordinate this in terms of noting down key risks, mitigating actions, and also who's going to do those actions and when they're going to be done by. And that needs to be clear so that all partners can feel confident in how key issues, barriers, risks are being resolved. And that's very important, you know, when we're working with other external partners, such as providers in the market, who might need some assurance about the type of risk that they're being asked to take on. So these are really significant meetings and can be really helpful as long as they're led properly. And the next level of escalation is really if that case discussion, you know, if people weren't able to properly meet or to reach an agreement on a solution, we would then escalate to more kind of senior level directors. This is only if all organisations agree that the escalation needs to go ahead, and each representative is responsible for briefing the appropriate contact should that further escalation be necessary. So this gives you some examples of the senior level managers that might be involved. This process ensures that cases are, you know, the idea is to resolve them in a timely and structured manner, but also with clear ownership and clear escalation pathways. So once senior staff have been briefed, there should be a call rapidly to agree next steps. And this is an opportunity also to identify any what we would call system failures. So that could be gaps in provision, could be unsuitable pathways, could be processes that haven't yet been put in place. And that can then be raised as a risk or an issue in the Urgent Care Committee for that particular area, as well as the Mental Health and Housing Forum that has now been set up. And I'm going to hand back to housing to talk about level 3, which is more specifically for unresolved housing issues.
Thanks, Amy. So if an individual agrees with the local authority's decision regarding their homeless application, they are entitled to request an internal review, often known as a Section 202 review. And then what that process is to allow the authority kind of reassess its decision, ensure it aligns with legal obligations and accurately reflects the applicant's circumstances at that time. So applicants typically have 21 days from receiving the decision notice to receive that request. So, you know, should be adhering to that time frame. And once it's received, the local authority will acknowledge the receipt, so inform the applicant of the kind of review timeline, might request further information. They'll then conduct that review based on all the information. There might be new evidence or information provided, and then again inform the decision to the applicant of that review outcome, including reasons for any changes or confirmation of that original decision. So typically a review officer will have 8 weeks to complete that review, subject to a kind of agreed extension for various reasons. It could be, you know, requiring further medical information. And if the applicant then disagrees with that review outcome, they can appeal that to the county court. And that must be lodged within 21 days of receiving the review decision. And then the court will examine whether the local authority's decision was legally sound and properly executed. It's back over to Amy, I think.
Thanks, Ickvinda. So this section looks at supporting individuals in mental health crisis. It's going to briefly cover some key interventions and available support pathways, and all of this is in the protocol if you want to look there for more information. So when someone is experiencing a mental health crisis or might be at risk of suicide, it's essential, obviously, that we all act swiftly and appropriately to ensure their safety and also provide that urgent support. So a crisis can happen when an individual feels like they urgently need help and their emotional or mental state may lead them to take extreme actions if not addressed quickly. And here is sort of some of the signs that might indicate that somebody is in crisis, and recognising these early could prevent harm occurring. When any of these signs are present, it's critical to get the person the right help that they need immediately. And the protocol sets out several immediate risk options and urgent support channels. And I'm going to talk through a few of those now. I'll just skip on to the next slide. So I think it goes without saying that if a person requires emergency support for an imminent life-threatening situation where there is an immediate and impending threat of death or serious physical harm to a person or others, we should be calling 999. However, there are instances where somebody requires urgent support, and that's when that individual has a few options and the professional has a few options as well. So that person could call 111, option 2 to go through to somebody who can support. They can also contact the mental health crisis helpline. They can make an appointment through their GP. And they can access the safe havens, which provide that kind of out of hours help and support. But there are lots of instances where that person wouldn't be able to do any of these things. And when that is the case, the lead professional can also call what's called the healthcare professionals line. There's the number there, and that is for people working in statutory or voluntary organisations. They don't have to be health or care organisations, so that would include housing, for example. And if the person is already under the care of the community mental health team, then that professional or the individual themselves could phone that team to discuss their concerns during office hours. So if it was outside of office hours, again, you could use the healthcare professionals line, or if they were able to, they could access the safe havens. So I'm going to hand back to housing. I think we're pretty much near the end now. Ikvinda, are you happy to talk through this?
Thanks, Amy. Yes, yeah, very much so. Coming towards the end. So last kind of major section we want to look at is managing benefits for individuals at risk of homelessness. So we'll look at covering new claims, rent arrears, and available financial support. We delve into that. When it comes to rent arrears, then speed is everything. Delays in payments can quickly put someone at risk of eviction, but in many cases, the issue can be resolved quickly with the right steps. And we're just going to go through some of the common causes of missed payments. And that would be unsubmitted review forms that delay benefits, suspended benefits due to unreported changes. So if you do identify a rent issue, like I said, act fast. You'd be contacting DWP via the Universal Credit Journal, reach out to the local housing benefit office within 3 working days. And if the person is returning home, and the housing benefit can continue up to 52 weeks, but it must be updated. It's really important also that we ensure that all details are correct in their universal credit account to prevent any further delays. And ultimately, with all the steps, they're simple but urgent steps, we can prevent evictions, reduce homelessness, and keep people in stable housing. Back to Amy.
Lovely, thanks, Ikvinda. So just finally then, this is our last slide, I'm just going to pick up on some of the key messages running through this. Hopefully these have come across, but collaboration is obviously essential. This work relies on very strong teamwork, and hopefully the protocol provides a clear framework for that. We do have a significant number of difficult challenges and issues that we need to work through, and we have to work effectively as a team in order to do that. Escalate where necessary. So if there are delays or misalignments with the protocol, or you feel like stuff hasn't been done when it should have been, those concerns need to be raised using that escalation process to really try and address issues before they escalate further. And a focus on solutions. So there are definitely, commissioning gaps, provision gaps, challenges, and our goal is to work together to try and find practical case-specific solutions. So obviously we need to understand the current barriers, but we also need to prioritise actionable steps that will help the individual move forward in the best way possible. And if there are systemic barriers and things that, they're not going to be resolved necessarily in that escalation process, but there are practical solutions that can help move things forward. The systemic barriers and issues can be raised at the Mental Health and Housing Forum, which is really a place to try and work together to move things forward. And using the protocol effectively, it is supposed to be practical and straightforward. Just go to the right section that you need. And there is also a session like this on Healthy Surrey where you can kind of access a shorter version of this training if you want to refresh that as well. And finally, as we said before, early intervention is key. Too often we hear about cases where the housing needs haven't been picked up early enough, or a referral hasn't been done early enough. And the sooner we can address issues, the better the outcomes really for everyone involved. So thank you, everybody. Oh, Jackie, thank you for your comment. That's nice. Michael, do we want to take any questions? And I think you've also got another poll for everyone.
So we do have a final poll. I'm just going to stop the recorder now because that was a fantastic session. So thank you so much, Emma, Ickvinder, Knowledge, Joe, and Amy. So I'm just going to stop that.